Hi, this narration covers pathophysiology for the GI system, including liver, gallbladder, and pancreas. The first chapter is chapter 35, which is an A&P review, so we won't be covering that. However, please be sure to do the activities that will help you to just refresh your memory on that. You also have SurePath assigned for this. So we'll move directly into alterations, which is chapter 36. First, clinical manifestations of GI dysfunction. We have a series of symptoms that characterize much of our GI disorder patho that we will see in various diseases. And so just to make sure that you know the definitions of all of these, we talked about these in class. Anorexia, a lack of desire to eat despite physiologic stimuli that would normally produce hunger. So physiologic stimuli that would normally produce hunger are things like the smell of food. So if you smell a pizza, for example, vomiting, forceful emptying of the stomach and intestinal contents through the mouth. Several types of stimuli initiate the vomiting reflex. Nausea is a subjective experience associated with a number of our GI conditions. Common symptoms of nausea and also vomiting are hypersalivation and tachycardia. Retching is like gagging, dry heaving, non-productive vomiting. Projectile vomiting goes, shoots across the room, is typically very sudden, is not accompanied by nausea. It's very forceful, and it does have some momentum behind it. Constipation, defined as infrequent or difficult defecation. Diarrhea is your increased frequency and volume, usually fluidity of bowel movements. Abdominal pain is very vague. We talked about that in class, saying that your stomach hurts could be anything from, a stabbing pain because somebody stabbed you, literally, or it could be that you're nauseous, And then GI bleeding, which is bleeding anywhere in the GI tract, which we also talked about in class and which we'll explore further in this narration. So pathophysiology of constipation, understanding why someone might be constipated, could be a neurologic disorder that actually causes some kind of functional condition where you are, for example, where you are paralyzed or you're, and if you have any kind of neurologic dysfunction and the nerves that are innervating the GI tract aren't working correctly, aren't providing the correct stimulus, then we can often see constipation. Functional mechanical conditions. Functional means everything looks fine, it's just not working right. So one of those examples would be some kind of paralysis. Mechanical conditions could be something that's actually there making you constipated. So for example, if you have an obstruction, be that if that excuse me, if that obstruction is caused by, a tumor, for example, you're going to get constipated. Low residue diet. Remember that your low residue diet is a low fiber diet. Fiber speeds everything up because it is an insoluble substance that draws water into the stool. Excuse me. So when you think low residue diet, think, things like pasta, mac and cheese, mashed potatoes. Fast food is very low residue because there's not a lot of fiber in fast food. What we think of as standard fast food anyway. I'm not talking about if you get a salad, Sedentary lifestyle. The more you move, the more you poop. And so when you're just sitting there, you don't get very much peristalsis, and the stool tends to get harder because all the water is absorbed. Excessive use of antacids. Like I said in class, when antacids are also, they cause constipation as a side effect. So most medications that are antacids are also antidiarrheals. And then changes in bowel habits. And the example that I used in class was the little kid who starts school and doesn't want to poop at school, therefore holds it until they get home, and then we've got a problem because at that point it's too hard for them to actually poop. And so then they get constipated because they can't actually push it out. Diarrhea mechanisms. So diarrhea, now there's a difference between having a loose stool and having diarrhea. Diarrhea is several loose stools, okay? Diarrhea is dangerous because we've got issues with absorption. Clearly, you're not going to absorb your nutrients if you have diarrhea because they just don't stay in there long enough. You also have dehydration and electrolyte issues. Dehydration should be fairly obvious. Your stool is very liquid. You're losing a lot more fluid than you normally will. The electrolyte issues, you poop out potassium, a lot of potassium, okay? And so when you have diarrhea, you're losing potassium, and that's one of the reasons that you feel so weak when you have a GI bug is because your potassium levels are likely very low. And if you remember back from fluid and electrolytes, you know that potassium is necessary for muscle strength and muscle contraction. If your potassium level is low, you're going to be very weak. Your muscles are going to feel weak. And so what do we do for that? We replace it. Best way to replace the fluid loss and diarrhea? An oral rehydration solution. So think Pedialyte, Gatorade, Powerade, whatever floats your boat there. So the mechanisms of diarrhea, I talked a little bit about this in class that it's not necessary that you really know the mechanism, just that whatever it is, more importantly, to know what happens with diarrhea, and that is the absorption, the fluid and electrolyte problems. Osmotic diarrhea that's what happens when you pull a whole bunch of fluid into the diarrhea or into the stool. So let's think that lots and lots and lots and lots of fiber intake. So fiber's insoluble. All it does is draw fluid into the stool. And so all of a sudden now you're pooping because you've got a ton of water in your stool. Secretory diarrhea is usually caused by the presence of an organism. So think your GI bugs here, okay? And then motility diarrhea is just caused by rapid peristalsis, hypermotility. It's not necessarily that we're drawing more water in. It's just that we're losing it too fast to reabsorb the water. And a lot of times motility-related diarrhea could be caused by certain foods. Prunes are notorious for causing motility-related diarrhea, and that's why we give prunes to people who are constipated. All right, abdominal pain. Remember, we've got a few types of pain. We're going to talk about parietal versus visceral pain. Remember that visceral pain is that organ pain that you can't really say, oh, my liver hurts or, my large intestine hurts. Visceral pain is usually referred, and that means that you feel it somewhere else. So that's, for example, why you can feel stomach pain sometimes in your chest or in your shoulder, okay? Parietal pain, though, typically is not referred, and you can actually say, my right upper quadrant hurts. That's your gallbladder, okay? And it's right there, okay? So it is irritated by the parietal peritoneum. All right, so GI bleed. We know that GI bleeding can occur everywhere from mouth to anus, and we just have this, random split between upper GI and lower GI. Upper GI is typically the esophagus, stomach, or duodenum, and those are caused by various things. And then lower GI bleeding is also caused by various things. So some terms here: hematemesis means that you are vomiting blood. Now, very violent vomiting, if you are vomiting a lot, very violently, like if you have food poisoning or something, sometimes you'll get little traces of blood in there. That is not typically dangerous, okay? That's just caused by a lot of irritation and the forceful, the force behind it, okay? Hematochezia is our fresh blood. So contrast that with melena, which is your black tarry stools, okay? So hematochezia means you've got a lower GI bleed tip, and if it's bright, if it's fresh blood, it's like right there, okay? So a lot of times that's going to be, so it's going to be rectal bleeding. A lot of times rectal bleeding is due to hemorrhoids, okay? Melena, that's our black tarry stools. At that point, we've got an upper GI bleed. It has a distinct smell. And it is, it's black, it's tarry, it has a distinct texture, look to it if you've ever seen it before. And it's very, I mean, it's pretty unique. One thing I didn't mention when we go back to hematemesis is that bright red blood is something actively bleeding in the upper GI tract. Coffee ground emesis means the blood's been sitting there and it's been digested a little bit by your stomach acids. All right, dysphagia, difficulty swallowing. Contrast this with the dysphagia with an S, which they're pronounced, I mean, they end up sounding the same way, but PHASIA is difficulty speaking, and GIA is swallowing, okay? People who are who are one are often the other as well, because it's a problem with the muscles that, in your throat and stuff. So, got a couple of types here. First, mechanical obstructions, and again, a mechanical and functional. So remember, functional, everything looks right, but it just doesn't work right. And so that's going to be the case with our stroke patients who have risk of aspiration because the muscles in their larynx, in their throat, just don't work right, okay? And a lot of times it's also in their mouth. So sometimes they don't feel that they have food on that side of their mouth or something like that. So, when you have functional or mechanical obstructions, though, here you actually have something in the way. And so, for example, if you have a tightened lower esophageal sphincter, then you can swallow, but it's going to fill up your esophagus, and then it's not going to go anywhere else. And once your esophagus is full, you're done. You're not going to be able to swallow anything else down. Okay, that's a mechanical obstruction. Achalasia means that the sphincter doesn't actually work. It's not there. And so as a result, that sphincter doesn't do what it's supposed to do. It doesn't tighten. And so it's completely relaxed, which means that things go up and down and up and down and up and down. Okay. You're going to get a lot of reflux with that. Speaking of reflux, GERD, and here's the lasagna Tums, or Tums lasagna. That would be just, oh God, as an Italian, I just have a problem with that. So GERD, gastroesophageal reflux disease, we call it GERD when it can't be managed by a once in a while Tums, okay? I mean, that's basically it. People will get reflux once in a while. People will get heartburn once in a while. Happens to everybody. It just depends on how late you eat, how spicy it was, did you eat too much, things like that, okay? So different, but once we have to treat you prophylactically and we have to keep the treatment up, that's when we call it GERD, okay? Babies get it too, remember, we just call it GER, and we don't attach the disease onto it. And we'll talk about that with the peds narration. So, because you've got reflux in there and there are acids in your stomach that don't belong in the esophagus, it can cause inflammation, and that is actually called reflux esophagitis. So normally, that lower esophageal sphincter should prevent that. But we've got various conditions, including the lack of development of that sphincter, but also there are risk factors for GERD, including we talked about hiatal hernias in class, which is, I think, the next slide. Smoking, alcohol, all of those are risk factors for GERD. Obesity is one. A high amount of abdominal, if you carry your weight in your stomach, so like beer bellies are risk factors for GERD. Pregnancy is a risk factor for GERD. Anything that can put pressure on the stomach to push that back up the esophagus. So anything like that. Manifestations, you're going to have heartburn. Reflux is different from heartburn. Heartburn is the burning in your chest. Reflux is where it actually hits your throat and you can feel the acid in your throat, okay? A lot of times people who get this will get pain, what we call the mid-epigastric pain, and it is called heartburn. The reason we call it heartburn is because heart pain is in the same spot, like right down, mid-sternal, right down the middle of your chest, okay? And a lot of people have this within an hour of eating, but it's not always then. A lot of times this is what wakes people up at night, especially if they eat late. Now, a hiatal hernia will cause GERD symptoms, only here we actually have a physical cause for it, okay? So it's not just something where we can say, oh, well, you just need to lose weight or something like that, or once you're not pregnant anymore, it's all going to be fixed. Well, no, we've actually got here, a mechanical problem, and that's where the stomach is floating above the diaphragm. And so a hernia, remember, is something sticking out somewhere it doesn't belong. And in this case, it's sticking through the diaphragm, and it's not supposed to. Your diaphragm is supposed to separate your lungs from your abdominal cavity. Sliding goes up and down and up and down. And then we've got the kind of where you just got this little loop of the stomach, which just always sticks up. We can do surgery on this, but like 90% of the time, people who have surgery for a hiatal hernia still have to take meds, and because it doesn't fix their GERD. And so a lot of people just say, well, I'll just take the meds and I won't go through a surgery. Now, pyloric obstruction, which with pyloric obstructions, a lot of times these are diagnosed in infants, okay? And this is where the pylorus, which is the opening between the stomach and the duodenum, so it's that sphincter, that pyloric sphincter, so now we're moving down, that's blocked. Now, it is usually congenital. You're usually born with it. But you could develop it later on in life. Now, if you think about it, your pylorus here, your stomach's going to fill up, and so you're going to get a lot of this epigastric pain and fullness. And this fullness, like I was saying in class, I don't remember if I told both sections, but my mom had a pyloric obstruction because a tumor had wrapped itself around the pylorus. And so she could eat, but then she felt very full and nothing passed out of her stomach. She just puked it up. And she wasn't really nauseous. She just, all of a sudden, everything just came back up because it couldn't go anywhere. A succussion splash is from things falling into the stomach when the stomach is still very full because nothing can move on. And then vomiting. And then eventually these patients are going to be very malnourished because they're not absorbing anything. If some gets through, not a lot gets through. Okay, dehydration because they're not absorbing the water that they drink. And we're talking extreme debilitation here. These patients have to receive supplemental nutrition somehow. Now, we can either put in a feeding tube lower on. It's actually what my mom had done. She had a tube placed in her jejunum until she went into hospice. The tube was still there, but that was how she was getting her nutrients. Or with TPN, which is straight into your IV. If you haven't learned that yet in fundamentals, you will. All right. So we talked about pyloric obstruction. Let's talk about obstructions in other places now. So any kind of intestinal obstruction, you can call it a small bowel obstruction if it's the small intestine, call it a large bowel obstruction if it's the large intestine. Large bowel obstructions, a lot of times are going to be tumors. That's going to be, just a simple mechanical obstruction. Anything that prevents the intestine or the food from passing through the intestines. Now, an ileus is another name for it, and a paralytic ileus is specifically what happens after anesthesia. If you have a long surgery, you're under anesthesia for a long time, one of the things that it does is it puts the intestines to sleep as well. It deadens those nerves, and so you don't have any peristalsis. If you don't have any peristalsis, then the chyme, or chyme, I don't know how to pronounce that word, that's the food, okay? That's all of your intestinal contents. It doesn't move. If your intestines aren't moving, neither is that stuff. So you don't have any bowel sounds, you don't pass gas, you don't poop, okay? And a paralytic ileus, if you have just come out of surgery, that's expected. It's expected that you're not going to have any bowel sounds. Bowel sounds come back first, then you start passing flatus. At the point where you are passing flatus, that's when we say, okay, everything's awake, we're good, let's start giving you some clear liquids. Used to be that as soon as you had bowel sounds, we did that, and then everybody puked because things weren't actually moving. They were just starting to wake up. What happens in the long run with this is that first of all, you're not getting any nutrients. Now, typically with a paralytic ileus, if it's just for a day or two, you can live. And we're giving you a whole bunch of IV fluids, so you're not going to die of dehydration. If we're talking like 6-7 days, we've got an issue because at this point, all of the bacteria in your intestines, remember I talked about this in class, bacteria need to be mobile, okay? If not, they continue to grow and grow and grow, and then they translocate out of your intestines and into your bloodstream, and then they cause sepsis. Okay, so we want to get things moving. When somebody's admitted to the ICU, we give them fluids. They're not going to get dehydrated and everything, but one of the first things we do is we put a feeding tube in because we want to keep things moving through the bowels. This is not, it's pretty fast, especially if we anticipate that they'll be there for a while because we don't want to put the added insult of sepsis on top of somebody. All right, I'm going to stop there. I'm going to pick up in the next narration with gastritis.